So these next few slides provide you with the acronyms that are used in this presentation. You also have an acronyms list that's within your packets, which is handout number 3. If you're unfamiliar with the acronyms that are used in nursing facilities or in the SNF QRP, it might be worth pulling that out and keeping it aside as we go through the presentation. So I'm going to kind of click through these couple of slides. So let's look at the objectives of this session. After participating in this session, you should be able to identify the relationship between the Impact Act and data collected for the SNF QRP, list at least 3 RAI manual changes, name 3 reasons item set changes were made, and list at least 1 new, 1 revised, and 1 removed MDS item. But first we're going to go over a very brief discussion on the Impact Act of 2014. The Impact Act was a bipartisan bill passed on September 18th of 2014 and was signed into law on October 6th of 2014. The Impact Act requires that patient-resident assessment data be standardized across post-acute care settings. And the idea is that having standardized assessment data, it would enable quality of care and improved outcomes, provide data element uniformity, the ability to compare quality and data across PAC settings, improve person-centered, goals-driven discharge planning, allow for electronic exchangeability of data, as well as to coordinate care across the post-acute care continuum. You may have seen this graphic before or one similar. It's really a visual of data element alignment across the post-acute care patient-resident assessment instruments with the goal of uniformity between them. Although this graphic really doesn't quite show the alignment that has been achieved, which is nearly 100% between the MDS and the LTAC care data set, and similarly across the IRF-PI, which is in the inpatient rehab facilities, it does provide the idea of what the goal is, which is data uniformity. So here are the goals and guiding principles of achieving standardized data. Some of the goals are to foster seamless care transitions with data and information that can follow the patient or resident, to assess quality across the settings, and evaluate longitudinal outcomes for patients or residents across care settings, and improve outcomes and efficiency to reduce provider burden. Some guiding principles are that the data should be reusable, informative, and meaningful to providers. It should increase reliability and validity, as well as facilitate care coordination. In terms of interoperability, having standardized data using the same language makes it easier to communicate across settings of care. That is, that the data can actually be transferred in both directions, that is, to and from providers to facilitate communication and care coordination, and importantly, to follow the individual wherever he or she may be. The relationship between the Impact Act and data collected for the SNF QRP is that there are reporting requirements in the Act which establish the SNF QRP in the fiscal year 2016 SNF PPS. Per the statute, SNFs that don't submit the required quality measure data may receive a 2 percentage point reduction to the annual payment update, or APU, for the applicable payment year. And for more information regarding the SNF QRP, you can always visit the SNF QRP website, and we will have a demo of that a little bit later, so you'll actually see where that information is. So why were there changes made to the MDS and the RAI Manual for 2019? Well, some were due to the Impact Act, which required that standardized data elements be implemented. Others were to align the content of items that support cross-setting quality measures, such as the pressure ulcer measure, medication reconciliation, and function measures. Some items, as we'll see, and some item sets were removed to reduce burden to providers. There were also some changes made due to quality measure changes, and of course, some changes were also made due to the implementation of the patient-driven payment model, or PDPM, which we will hear more about tomorrow. Okay, so now we'll move on to discuss the revisions in the RAI Manual and the item sets. And here's just a list of changes to the RAI Manual by chapter and section. We're mostly going to discuss the changes that are not otherwise discussed elsewhere in the training. So for sections A, G, G, I, J, and O, we'll be going over those changes in those presentations, so I will not go over them during this presentation. So let's start with some high-level changes that have occurred in the manual and item sets, and talk a little bit more in depth of some of those changes as we go along. These global changes listed on the slide, next couple of slides, are changes that have occurred throughout the manual. Acronyms have been spelled out for the first time they're used, and then the acronym is added parenthetically following. The URLs or links to items have been updated, typographical and grammatical errors have been fixed, and where page numbers have been used as a reference before, we're now going to reference the section or the chapter that information can be found. Because as you can imagine, in like a 1,000-page manual, to have to go back and look for where page numbers were referenced, it's quite a task. CMS has also standardized the acronym for the Quality Improvement Evaluation System Assessment Submission and Processing System, or KEYS ASAP. So that's what you'll see throughout the manual now. Pressure ulcer has been revised to pressure ulcer injury where appropriate, and the phrase mental retardation in federal regulation was removed when referring to intellectual disability. There also has been guidance added throughout the manual in relation to the 2 new item sets that have been added, one which is associated with the new patient-driven payment model, and the other having to do with reporting for state payment purposes, and we'll talk a little bit about that later. Because the term Medicare refers to Medicare beyond Part A, so there's Part B, Part C, the term Medicare has actually been replaced with Prospective Payment System, or PPS. For example, where the terms Medicare Assessments, Medicare Requirements, and Medicare Schedule were used, the references are now PPS Assessments, PPS Requirements, and PPS Schedule. And finally, throughout the manual, all references to the 14, 30, 60, and 90-day PPS assessments, all of those OMERs which you loved, and the swing bed clinical change assessment have all been removed due to the new PDPM, under which these assessments are no longer necessary. So I hope that made a lot of people very happy. So there are 2 new assessment types and items that go with them, item sets that go with them. They're both optional assessments. So keep that in mind. They are optional. John Kane has said many times that providers have come up to him and said, no, the IPA really isn't optional. And yes, it's optional. It is provider optional. So that's the first assessment I'm going to talk about. It's the Interim Payment Assessment, or IPA, which is signified by coding A0310B equals 08. And the second is the Optional State Assessment, or the OSA, which is signified by coding A0300 equals 1, or yes. For the IPA, the assessment reference date, or ARD, can be set for any time after the 5-day. If providers opt to use this assessment, it must be completed at Z0500B within 14 days after the ARD and needs to be submitted within 14 days of completion. Be aware that completion of this assessment will change the payment for the rest of the PPS day. So the 5-day, when you submit the 5-day, that sets the payment for the entire SNF stay. And if you complete the IPA as of the ARD, that will change your payment. So be aware of that. Regarding the OSA, again, this is an optional assessment. It is not federally required. It's an assessment that may be required by the state agency for payment purposes. This set of items include the items that are required to calculate the Resource Utilization Group, or RUG, 3 or 4 scores. I'll talk a little bit more about this tomorrow, but on the OSA only, you're going to notice that there is an item AO300B, which allows you to select the type of assessment being completed for state purposes. You're not going to see that AO300B on any other item set but the OSA. Okay, the other important thing to note is that these are both standalone assessments and they can't be combined with any other assessment. So let's go into Chapter 2. There are a lot of changes that have occurred here, as you can imagine, with the removal of all those item sets. As you can imagine, as I said, there's been a lot of changes here. There are, however, a couple of overall changes in Chapter 2 that have occurred, so I'm going to talk about that first. And the first is revolving a new policy called the interrupted stay, and that is associated with the PDPM. And then we're also going to look at the implications of the new item sets based on policy. So be sure to review Chapter 2 thoroughly so that you're fully aware of all of these changes. Under the change of ownership section, and due to the addition of the IPA, the change of ownership information under the common situation, where an owner resumes the assets and liabilities of the prior owner, was revised. If the resident is in a Part A stay, an IPA could be the next PPS submitted under the existing provider number if the 5-day had been combined with the overadmission. Just remember that if this does occur, your payment is going to change the remainder of the Part A stay unless you complete another IPA. Before we talk more in depth about the changes in the 5-day assessment window, I just wanted to reflect on the fact that there are now only 3 PS assessments. 3. So it's the 5-day, the IPA, which is optional, and then we still have the Part A PPS discharge assessment. No more OMRAs and no more of anything else. And I see a few thumbs up out there. So let's now take a look at the changes that have been made in the 5-day assessment window. The 5-day has defined days, as you know, within the ARD at item A2300 in which the ARD must be set. The prescribed window to set the ARD for the 5-day is now days 1 through 8. So there are no more grace days. They've kind of been folded into the actual ARD of the 5-day. And the ARD, of course, must still be set on the MDS form or in the facility software before that ARD window has passed. The first day of Medicare coverage for the current day is considered day 1 for PPS scheduling purposes and for purposes of the variable per diem or VPD adjustment, which you will learn about more tomorrow. And you can also find this information in Chapter 6 of the RAI Manual. In most cases, the first day of Medicare Part A is usually the day of admission. However, we all know that sometimes there are situations where the beneficiary may qualify for Part A a little bit later in the stay. So here's a little bit more information about the 5-day assessment that was added to the scheduled and unscheduled assessment section in Chapter 2. As you can see here, this addition refers to the setting of the ARD on days 1 through 8. And also in this same section, information about the IPA has been added to show that the IPA may be completed after a 5-day when deemed appropriate by the provider. The IPA captures changes in the resident's status and condition, and remember that it will change payment for the remainder of the Part A stay. So here's more detail about the 5-day assessment. Again, the ARD must be set for days 1 through 8, and it must be completed as indicated by the date in item ZO500B within 14 days after the ARD, or the ARD plus 14 days. The 5-day authorizes payment for the entire PPS stay until the provider opts to complete the IPA. The 5-day is still the first PPS required assessment to be completed when the resident is first admitted for a SNF Part A stay. And the 5-day will also be the first assessment to be completed if the resident is readmitted to the facility for a Part A stay following a discharge assessment return not anticipated, or if a resident returns more than 30 days after a discharge return anticipated. The 5-day, however, is not required if a resident returns to a Part A stay following an interrupted stay. And I'll talk more about the interrupted stay policy shortly, but just remember that a 5-day is not going to be required in that situation because in effect, the interrupted stay does not end the Part A PPS stay. If a resident changes payers from Medicare Advantage to Medicare Part A, the SNF must complete a 5-day assessment with the ARD set for one of the days 1 through 8. With the resident's first day covered by Medicare Part A serving as day 1 unless it's an interrupted stay. So let's look at the IPA. There are situations where a provider may want to complete an IPA to capture changes in resident status and condition. Again, the IPA is solely under the discretion of the provider to complete as it's an optional assessment. Should the provider want to complete an IPA, the ARD can be set for any day of the SNF PPS stay as long as it is after the ARD of the 5-day. If the provider chooses to complete the IPA, it must be completed within 14 days of the ARD. And again, the IPA authorizes payment for the remainder of the PPS stay beginning on the ARD. It must be submitted electronically and accepted into the KEYS ASAP system within 14 days after completion, and this assessment may not be combined with any other assessment, PPS or OBRA. It is a standalone. Information was added to the Part A PPS discharge section to accommodate the interrupted stay policy. Under our current requirements, the Part A PPS discharge is completed when the resident's Part A stay ends and he or she remains in the facility. A0310H identifies whether the discharge is a Part A PPS discharge for the purposes of the SNF QRP. This requirement remains the same except in cases where there is an instance of an interrupted stay. So how does the interrupted stay policy affect the completion of the Part A PPS discharge assessment? So I'm going to quickly describe what this policy is so that you have a little bit more context. The interrupted stay is a policy that when the resident is in a SNF stay, is discharged from SNF care, that is, they're discharged from Part A, they either physically leave the facility or remain in the facility, and they subsequently resume SNF care in the same SNF for a Medicare Part A stay within an interruption window. The interruption window is a 3-day period that starts on the calendar day of discharge and includes the 2 calendar days immediately following, ending at 11:59 p.m. on the end of that 3rd calendar day. If these conditions are met, The subsequent stay is considered a continuation of the previous Medicare Part A stay for purposes of the variable per diem and PPS assessment completion. So this goes back to what I said, the PPS stay actually doesn't end in an interrupted stay. If the resident was discharged from Part A, remained in the facility, but then resumed Part A within the 3-day interruption window, that's an interrupted stay. Therefore, there's no Part A PPS assessment that's required, and this, again, is because the PPS stay didn't end. However, in the instance where a resident's Part A stay ended, the resident remained in the facility and the resident resumed Part A outside of that 3-day interruption window, the Part A PPS discharge assessment would be required, and on resumption, the PPS schedule would start over with a 5-day. Make sense? Okay. If the resident physically leaves the facility for an interrupted stay, so that, again, is the Part A stay ends, the resident leaves the facility, but they come back to resume Part A within that 3-day window. An OBRA discharge is required, and on return, an entry tracking record, but no new 5-day would be required. And again, this is because in an interrupted stay, the Part A stay did not end. So as you've noticed, the OBRA rules still remain. So if somebody leaves the facility, they need an OBRA discharge. And when they come back, they need an entry tracking. So that's really important to remember. In this situation, actually, an IPA could also be completed, but be careful if you do, because your payment's going to change based on that IPA. So now we're going to look at the entry, OBRA, discharge, and reentry algorithm that's in the manual. It's been updated to remove items A0310C and A0310D in the footnote of the diagram, since those items are no longer on the item set. In section 210, which is the combining PPS assessments and OBRA assessment section, obviously there's new information in there related to the IPA, and information was removed. As you know, the OBRA and PPS timeframes coincide. One assessment can be used to satisfy both requirements, and this still holds true. And you're going to follow those requirements as you always have. One thing to keep mention of, though, is that the 5-day now has that 1 through 8 window, and your OBRA has that 14-day window. So in order to avoid a late assessment, make sure that you put that ARD for a combined assessment between those days 1 through 8. Additional updates to this section include the updates to the tables that denote item sets by assessment type for SNFs and swing beds. Those were updated to include the revisions to the 5-day, add the IPA and swing bed discharge, as well as the types of combination assessments. There was also a statement in this section that read that tracking records cannot be combined with other assessments, and the IPA was added to this statement because that is also a standalone that cannot be combined. Section 2.11 details the assessment combinations. Each of the assessments listed here had all that combination language modified based on the new assessment window and of the 5-day and the elimination of the grace days in the various PPS item sets that have been eliminated. All that language has been removed from all of the combination language there. Okay, so there have been quite a few changes here in section 2.12, which is the section that talks about factors impacting SNF PPS assessment scheduling. Information was added to this section to accommodate the new interrupted stay policy, which we covered already. So I'm not going to spend a lot of time going through all the details, but I'm going to highlight some important information here. In this portion of section 2.12, the interrupted stay has been added to when a resident is admitted to an acute care facility and returns. If a resident under a Medicare Part A stay is admitted to an acute care facility and returns to resume the Part A stay, we know that a new 5-day is usually required. But we just learned that in an interrupted stay, as long as the resident returns to the same SNF and resumes Part A services within that 3-day window, a 5-day is no longer going to be required under that situation. Again, a provider could choose to complete an IPA. The next situation is where a resident is sent to an acute care facility, not admitted, and is not in the SNF over midnight. The current policy is that if the resident was in an acute care facility for less than 24 hours, no new 5-day is required. The addition here is that the IPA may be completed if the provider deems appropriate. The payment implications in this situation remain the same as they've always been, and that is that the day preceding the midnight on which the resident was absent from the nursing home is not a covered Part A day. In addition, that day would also be skipped for the purposes of the PDPM variable per diem adjustment, and that is described in Chapter 6, and we'll talk about it more tomorrow. In the case where a resident takes leave of absence from the facility, a phrase was added here that there may be payment implications. And the example given here is unchanged from current information that's already in this section. And if the resident has a leave of absence during part of the assessment observation, the facility may include services provided during that absence when permitted by MDS guidelines. When a resident is discharged from Part A and physically from the facility and they return to resume Part A services, the OBRA and Part A PPS discharge would be required and may be combined. On return to the facility, that would be considered a new Part A stay, as long as resumption occurs within the 30-day window allowed by Medicare, and a new 5-day and entry tracking record would be completed. If the resident was discharged, return not anticipated, the facility would also have to complete a new OBRA admission. However, in cases of an interrupted stay, only the OBRA discharge would be required and an entry tracking record would be required on return, but no new 5-day. If the resident was discharged return anticipated, no OBRA admission would be required, but if the resident was discharged return not anticipated, the facility would have to complete a new OBRA assessment. In the situation where a resident's Part A stay ends, but the resident remains in the facility in a Medicare and a Medicaid certified bed with another payer source, the facility must continue with the OBRA schedule from the date of admission, and they would need to complete a Part A PPS discharge. If the Part A benefits resume, again, there is no reason to change the OBRA schedule. The PPS schedule, though, would start again with a 5-day, unless it is the case of an interrupted stay. Then no Part A PPS discharge would be required and no 5-day would be required on resumption. The next portion of this section refers to noncompliance with the PPS schedule. So according to the Code of Federal Regulations, an assessment that does not have its ARD set within the prescribed ARD window will be paid at the default rate for the number of days that the ARD is out of compliance. Frequent late assessment scheduling practices or missed assessments may result in an additional review. And the default rate in this case would take the place of the otherwise applicable federal rate. That rate is equal to the rate paid for the Health Insurance Prospective Payment System, or HIPS code, that reflects the lowest acuity level for each PDPM component, and would generally be lower than the Medicare rate payable if the SNF had submitted an assessment according to the prescribed assessment schedule. If the SNF fails to set the ARD within the defined ARD for a 5-day and the resident is still on Part A, the facility must complete a late assessment. The ARD can be no earlier than the day the error was identified. The SNF would bill the default rate for the number of days the assessment is out of compliance, and that is the number of days between the day following the last day of the available ARD window and the last ARD, including the late ARD. The SNF would then bill the HIPS code established by the late assessment for the remainder of the SNF stay, unless the SNF chooses to complete an IPA. For example, if you had a 5-day with an ARD of day 11, it's 3 days out of compliance. And therefore, you'd be paid at the default rate for days 1 through 3 of the Part A stay, and the HIPS code from the late 5-day assessment would be used for the remainder of the Part A stay unless you complete an IPA. Make sense? Section 213 is the expected order of MDS records, and 214 is the nursing home and swing bed item set code reference tables. Those were updated to include the IPA and to remove the retired PPS assessments. There are 2 additional item sets that are not listed in this table. The first item set is related to inactivation request records. And that type of record, as you know, is an inactivation, and it has an item set code of XX. The second item set is that new item set, the OSA, which again is not federally required. It may be required at the discretion of your state agency. It calculates the RUG 3 and 4 HIPS codes. And this item set has an ISC code of OSA and is indicated by coding A0300 equals 1, yes. So now let's move on to Chapter 3 for the changes here. The first change is in Section D, which is the mood section. The safety notification items in the PHQ-9 and PHQ-9OV were removed. These items used to be completed when items D0200I and D0500I were coded 1 yes. Although you'll no longer see this on any item set, I think it goes without saying that if staff see this kind of thing, that they should be reporting that potential harm to the appropriate practitioner to ensure a proper follow-through for the resident. There were also items in Section K that have been removed. And these items are in K0510 nutritional approaches and K0710 % intake by artificial root. These were references removed regarding potential state requirements for completion of items that are no longer collected by CMS. And there was text in Section K and elsewhere in the manual regarding items that are no longer collected by CMS that were also removed. So under nutritional approaches, mechanically altered diet and therapeutic diet are no longer collected by CMS if the resident is not a resident. So as you can see in the new snapshot of the item, the checkboxes for KO510C1 and KO510D1 have been removed and blacked out on the item set. In K0710, percent intake by artificial route, items K0710A1, the proportion of total calories received through parenteral or tube feeding while not a resident, and K0710B1, average fluid intake per day by IV or tube feeding while not a resident, are both removed. And that's due to the fact that the while not a resident column is no longer being collected by CMS. So as you can see in the new snapshot, we're starting with column 2 now. The next item we'll look at is the respite care item, and that's in O0100L. This item has been removed from the item set altogether as it's no longer being collected by CMS. And as you'll see in item V0100, items from the most recent OBRA or scheduled PPS assessment, that the items were removed in section A that denote the prior PPS scheduled and unscheduled assessments that have been retired. Those were also removed here in section V, and the IPA was added. Due to the addition of the OSA, changes were made in section X, correction record. The item X0570, optional state assessment, was added. And this item contains the reasons for assessment from the prior erroneous OSA record to be modified or inactivated, as indicated in A0300A and B. The coding instructions require you to fill in the box with the assessment type codes exactly as submitted for A0300B assessment type on the prior erroneous record to be modified or inactivated. So just like the other section X items, they need to match section A exactly. In an item X0600, the type of assessment and tracking, this is the match of A0310 type of assessment on the existing record to be modified or inactivated. As you can see here, the retired PPS assessment response codes have been removed from X0600B, and X0600C and D were also removed, and the IPA was added. The corresponding instructions related to the removal of these items was also removed from the manual. In X0600-900, reasons for modification were also updated. And this was to remove the retired PPS assessment response code X0900E, the end of therapy resumption EOTR date. The related manual instruction for this item was also removed. Z0100 Medicare Part A billing. The term RUG was deleted from Z0100B so that it now just says version code. And the parenthetical statement Z0100A, RUG group followed by assessment type indicator, was also removed. Z0100C, is this a Medicare short stay assessment, was removed as this policy no longer exists under PDPM, and language related to this in the RAI Manual was removed as well. The rationale for Z0100 was updated to include language related to the PDPM case version code and the HIPS modifier based on the type of assessment completed. The definition of the HIPS code was updated to include information related to the PDPM. And item Z0100A, Medicare Part A HIPS code, is a 5-position billing code with the first 4 positions representing the PDPM clinical case mix, and the 5th is the assessment type indicator. If your software doesn't calculate this code for you, you can use the worksheets in Chapter 6 of the RAI Manual to help you. Like the RUG code, the HIPS takes into account all MDS items used in PDPM logic, but does not include the values in item Z0400 therapies. And typically the version code is calculated for item Z0100B, but if it isn't, you'll just enter the PDPM code there. In Z0150, Medicare Part A non-therapy billing, this was removed as it's not needed under PDPM. Z0200 and Z0500, these items have been updated to remove the term RUG, and additionally Z0200C, is this short stay assessment, has now been added here for the states that need it for their RUG score. In the insurance billing item, Z0300, the term RUG was removed here as well from both Z0300A and B. And for Z0500B, the signature of RN Assessment Coordinator verifying assessment completion, the italicized print on this slide was added. Use the actual date that the MDS was completed, reviewed, and assigned as complete by the RN Assessment Coordinator. This date must be equal to the latest date at Z0400 or later than the date at Z0400. Basically, this is saying that the date can be on or after the dates in Z0400. And now we're on to Chapter 5, where there have been some changes. In section 5. Yes, in section 5.7 of the chapter, CMS has decreased the number of years that a correction can be submitted. It's decreased from 3 to 2 years. The submission timeframe for MDS records table has been updated to include the IPA and remove those other assessments that have been retired. And fatal record error information has been updated to reflect the rejected records must be corrected and resubmitted unless that fatal error is due to a submission of a duplicate assessment. So in that case, you're not going to submit another assessment because there's already one in the system. And now back to the HIPS code. The HIPS code information was updated to state that the HIPS codes are billing codes used when submitting Medicare Part A SNF claims to the Part A or B Medicare Administrative Contractor, or ABMAC. And the HIPS code consists of 5 positions under the PDPM. As you can see this in this graphic, the first position is the PT-OT payment group. The second is the speech-language pathology payment group. The third is the nursing payment group. The fourth is the non-therapy ancillary group. And the fifth is that AI code, or assessment indicator code, indicating what type of assessment was completed. The grouper language was updated to remove references to RUG 4 and replace them with PDPM, as seen in the italics on this slide. And the HIPS codes used for the Medicare Part A SNF claims that are included on the MDS and are the items A0100A and B, which we've already gone over. In the last chapter we're going to look at is Chapter 6. As you can imagine, there have been a lot of changes here. The actual change table of Chapter 6 of the RAI Manual notes that there have been extensive changes in this chapter, so be sure that you review all of those changes in entirety. Highlights of the changes in this chapter related to PDPM include changes to the HIPS code, as were just reviewed, changes in the classification categories, clinical and functional, based on section GG, the addition of the PDPM component tables for the first through the fourth characters of the HIPS. The AI code table has been updated to include the IPA and the 5-day, and there's new language about the interrupted stay policy, as well as about SNF non-PPS compliance and related to late and missed assessments. So section 6.3 describes the PDPM, and it's important to mention again that the amount of therapy provided does not come into play when determining the payment under PDPM. However, the PDPM does adjust the payment for each major element of a resident's SNF care, especially PT, OT, speech, nursing, and non-therapy ancillaries. In section 6.6 is where you'll find the PDPM calculation worksheets, so they've all been updated. When you complete these calculation worksheets, first there's going to be a calculation of the resident's cognitive level, and then the worksheets go on to guide you through the steps to identify the resident's primary diagnosis, clinical category, function score, case mix groups, and payment component tables to obtain the payment component for PT, OT, speech, nursing, and the non-therapy ancillaries. There's also a calculation for the variable per diem adjustment and a calculation of the total case mix adjusted per diem rate. And finally, there have been some changes in the appendices. In Appendix A, the definitions and acronyms were updated. The definitions that were added were the interrupted stay and patient-driven payment model. And all the acronyms on the right side of this table were used in this presentation outside of Social Security number, which is SSN, and TPN, which is total parenteral nutrition. In Appendix C, pressure ulcers was changed to pressure ulcers injuries, and the URL to the Alzheimer's Association resource page was updated. And in Appendix G, the URL was updated for the MDS 3.0 Provider Users Guide. So I realized that this was like rapid fire, and thankfully you have your presentations and you have your manuals. When it's published, you can look at all of this. And so hopefully in this lesson, you still learned something, the relationship between the Impact Act and the data collected for the SNF QRP. And hopefully you learned about the RAI manual changes and the item sets and why those changes were made. So as Bridget mentioned, you have handout number 4, which is the action plan. If you learned something today that you need to take back to your facility about the changes in the manual, if you have to update policies, you can record it there on the action plan under this presentation. And now I'm going to turn the podium over to Alice Smith, who is going to be giving you an overview of the SNF QRP measures.